Hi, good morning. This is a particular scenario. It's a multiple choice question. I've turned it into a scenario so that I can, sort of integrate many subjects into one clinical spotter. So we'll try our best to make some clarifications. So this is the base of the skull. The anterior cranial fossa, the middle cranial fossa, and the posterior cranial fossa. It's as simple as that. If you really look at it, there are a lot of cranial nerves exiting in the middle cranial fossa. This you keep in mind so that applied anatomy will become easier. Understanding head injury will become easier. As I told you, these online sessions are never a shortcut for your clinical postings. So now this is your skull. Your anterior cranial fossa is there. This is your anterior cranial fossa, middle cranial fossa, and your posterior cranial fossa. Simple. Now what happens when a fracture line passes through the anterior cranial fossa? You will have bleeding from the nose. This chap doesn't have, but you will get bleeding from the nose. Now if it goes through the middle cranial fossa, yes, he will have bleeding from the ear. And not only that, multiple nerves can get injured. Most of the nerves will be exiting through the middle cranial fossa. That's why you'll repeatedly see MCQs where the fracture, the base of skull, open base of skull is kept, and they'll be invariably pointing to some foramen and asking you what structure exits that foramen. So this is the clinical basis also. What about the posterior cranial fossa? If there is a fracture line going through the posterior cranial fossa, there is no orifice for them to bleed externally. So what happens? They will bleed through they will have subcutaneous ecchymosis behind the ear. So as I told you, cranial nerve palsies in the middle cranial fossa can be a whole lot of palsies. Now what I wanted to stress for the anatomy students as well as the surgery students, now this battle sign which you see behind the ear, very difficult to see in dark skinned individuals. Most of the time there will be a lot of hair also. Now to move the head up and down and to go and look for that sign is not that practically possible and also needed. You found it, good enough, but don't go looking for it. Now you need to take care of his head injury, not to demonstrate clinical signs. You will be doing the CT scan now. You know he is very sick, that's why he's already been intubated. I am telling you the practical difficulties of flashcards which are thrown for your MCQs. If you understand both, then you know that the MCQs have been made purposely simplified so that you get to the root of the concept. In the grassroots level, things can be quite different. As I told you, the seventh nerve can be involved. And what do? You see this chap, this photograph is from Dr. Sham, it's not from my collection. When you ask him to show his teeth, what happens? When you ask him to close the eyes and show his teeth, you realize the orbicularis oculis is paralyzed. He is not able to close because that is supplied by the facial nerve. The zygomatico major is also supplied by the facial nerve. What happens here? It is weak. So it doesn't show it as weak here. It shows it as strong here. That's why it is deflecting to the normal side. This you must understand in lower motor neuron in the facial nerve. Whereas in the hypoglossal nerve it is different. I'm not going to go into the rest of the cranial nerves. This part you must understand. In a hypoglossal nerve palsy, the tongue will deviate to the same side as that of the lesion. Whereas in a facial nerve palsy, the angle of mouth will deviate to the opposite side. Now that is as far as concerned, it was for the anatomy students. This is also for the anatomy students. Let's come to a carotico cavernous fistula. You know the cavernous sinus there, and then you have the fistula. That is the carotid, the artery has ruptured into the venous sinus. That is known as a fistula. Now, how do you make it out clinically? This can happen in fracture middle cranial fossa. They will have, this is for ophthalmology students, you have proptosis, conjunctival hyperemia, chemosis, glaucoma, and it can even lead to vision loss. There can be injuries of other cranial nerves also. And this leads to increased blood volume, and the rest is available for reading in the slide. You can see these nerves. So naturally these nerves, even if they are not injured, they are going to be involved in the high pressure zone. There is a high pressure zone here. And what do? You can use a Doppler ultrasonogram. You can do a whole lot of investigations, but then the angiography will tell you exactly where is the communication between the artery and the venous plexus. It will show you how big is the communication, where is the communication, so that you can tailor your treatment accordingly. So now this is a carotico-cavernous fistula. Now what you see a third nerve palsy. There is drooping of the eyelids. It's an ophthalmic finding. You do a CT scan, you do an angiogram. You do an angiogram, you find out that the venous plexuses will get opacified in no time. There is a timing. The contrast is given through the veins. It's not given into the artery when you do an imaging angiogram. When you do a conventional angiogram, the contrast is given straight into the artery. But when you do an imaging angiogram, like your CT angiogram, CT venogram, or your MRI angiogram, you inject contrast into the vein only. After giving it in the vein, of course, it has to go to the right heart, then it comes into the left heart, and then it goes to the rest of the body. So once it reaches the carotid circulation, arterial circulation, it will immediately fill up the cavernous sinus, and that's how you will be able to make out. Then there are further studies to find out where exactly is the problem so that you can decide on your treatment. We are not going to go into the details. This is one of our patients. As I said, your anterior cranial fossa can also have raccoon eyes, black eyes. See here. Not only bleeding from the nose, but also raccoon eyes. Whereas your posterior cranial fossa will have some ecchymosis behind the ear. And your middle cranial fossa is going to have bleeding from the ear. Let's leave that. It was just a short recap. Coming to your carotico-cavernous fistula, you will have exophthalmos. There is increased venous tension there, ecchymosis, and also chemosis. What do? The only treatment will be interventional radiology. That is, you localize the fistulous tract with your imaging techniques and try to embolize the tract with various materials. I am not going into the details of those materials because that is not the objective. My objective was to take 2 slides from a bigger head injury presentation and integrate anatomy and ophthalmology. So thank you, and please do subscribe.